Well, hello, and thank you for joining us on today's special event as we bring thought leaders to the table to discuss the current and future state of interoperability. I'm Carol Feig of Answers Media Network and Healthcare Now Radio. We appreciate your time today. This year's panel will focus the conversation on the proposed interoperability and patient access rules. As this is a virtual panel discussion, this event is best viewed in full screen on your computers, laptops, or tablets. Also, we're scheduled to go 75 minutes, and a copy of this recording will be sent out to you post-event. This event is brought to you by eFax Corporate, a brand of J2 Cloud Services. J2 is an award-winning provider of internet services through its two divisions, Business Cloud Services and Digital Media. For more information about eFax Corporate, please visit enterprise.efax.com. Back with us again to serve as moderator is healthcare attorney Matt Fischer, a partner in the law firm of Remark O'Connell. Matt focuses his practice on health law in all areas of corporate transactions, including advising clients on complying with requirements of HIPAA, the Stark Law, the Anti-Kickback Statute, and other regulations in the context of daily operations, contractual arrangements, and relationships. He's a co-chair of the American Bar Association Health Law Section's Distance Learning Committee and a vice chair of both the Emerging Issues in Health Law Conference Planning Committee and Marketing Committee. Matt also hosts Healthcare du Jour, a radio and podcast show that airs on our own Healthcare Now Radio. Learn more about Matt at myrickoconnell.com. And now I'll introduce today's panelists. Dave Cassel is the Executive Director of Carequality and has worked for over 20 years in health IT, is creating a national reputation as an expert in health information exchange. Dave is responsible for the Carequality Interoperability Framework, which enables health data sharing across and among different types of networks. Under his leadership, the national level Trusted Exchange Framework was first implemented in July of 2016 and has rapidly grown to include more than 600,000 providers across more than 1,500 hospitals and 40,000 clinics, currently sharing more than 56 million documents a month. Jeff Whoops. Looks like we're picking up something. Jeff Coughlin is the Senior Director of Federal and State Affairs at HIMSS, a global cause-based not-for-profit organization focused on better health through information and technology. In this role, Jeff leads HIMSS efforts to build stronger relationships with federal agencies and facilitates the building of a nationwide network of advocates for state-based initiatives that impact all aspects of health IT. Chris Muir is the Standards Division Director for the Office of the National Coordinator for Health Information Technology and has been with the ONC since January of 2007. He has worked in state and federal government for over 26 years. Prior to this position, Chris was a director for the State Health Information Exchange Cooperative Agreement Program, in which the ONC awarded over $500 million in grants to enable health information exchange in each state. And complementing our panel today is John Nebrogoff, the Senior Vice President and General Manager of J2 Global Fax Business Unit. John is an accomplished senior executive with over 30 years of operating experience in the compliance space with a particular emphasis in health IT. He's also an adjunct professor of clinical informatics at the University of Illinois, Chicago, and is a certified public accountant and earned his undergraduate degree in accounting from DePaul University and an MBA from the University of Chicago. And now I'll turn the discussion over to Matt and our panelists.
Hey, thanks, Carol, and welcome everybody to the panel. So I think we'll just kind of kick stuff off and get right into the main part of our discussion. And the first topic I'd like to kind of steer everyone to is the promotion of APIs as a way to help with the ability to access and share data. I think we've probably all seen a lot of suggestions or touting of APIs as some sort of a solution, if not a silver bullet, which seems like it might be a little bit of a hype in terms of fully solving interoperability. So I'd like to get each of your impressions in terms of where you see APIs actually fitting into the interoperability ecosystem, and what are the realistic expectations around how APIs will provide a benefit. And Chris, if you don't mind, I'll go to you first, since I know that APIs have been a part of some of the proposed rulemaking, and also appreciate that you probably can't get too much into specifics of what is still a pending rule.
Yeah, no, thank you very much. So as you indicated, APIs isn't currently, I think, a full solution for interoperability, but I think it's very helpful for certain use cases, particularly when it comes to consumers getting access to data that might be in an EHR, or providers accessing data also in particular EHR. Also, we've seen some apps where patients can go and consolidate information from an app through different, so maybe more than one EHR or other health information technology system. So that's kind of right now, I think that's the state of the art. I think in the future, though, it can play a much bigger role.
Yeah, I think we at HIMSS look at APIs as a real significant piece of the puzzle moving forward, the interoperability puzzle. There are obviously between the ONC Interoperability Information Blocking Rule and the CMS Interoperability Rule. I think we saw a strong emphasis on the use of APIs, and I think that the government will continue to try to figure out how best to kind of push the entire field forward.
I think that APIs are, in thinking about the things that they solve. I mean, connectivity is certainly a big plus for APIs. It gives you the opportunity to expand the healthcare ecosystem, allowing applications to share data, and certainly expands vision, because an open API strategy can support future healthcare technology strategies like FHIR. But we have to be careful that APIs really don't solve your integration problem. End systems are still going to require some defined message standards dictated by their clinical systems in order to truly be integrated. Workflow is certainly the most complex interoperability challenge when you come right down to it, and the API is really a conduit. It's not going to solve that problem. And finally, services to do something with that connection need to be thought through as in an environment that is not right in the API, but ancillary to it.
I would broadly agree with all of what's been said there. I think it is helpful actually to take a little bit of a step back and make sure that we're all using the same language when we use the term APIs. I believe what is generally thought of as we see that term in rulemaking and as we talk about it colloquially is a FHIR API, for those who understand that acronym. And really what that is a way of performing a call into another system that is relatively lightweight and is intended to access a specific kernel of information, if you will. So getting at medications via an API, getting at a problem list via an API. For those of us who have some more technical elements in our history, an API is really everything that we've done in interoperability for a long time. Is an API of sorts. So I think it's helpful just to set that context. We're really here, I think, talking about FHIR APIs and similar constructs. But that said, I would agree that they're a really important piece of the puzzle, and they are exactly that. But they're a piece of the puzzle. There are, as you look at the full spectrum of what we need to truly achieve interoperability, I think there's going to be a place for a long time for the sort of workhorse HL7 kinds of interfaces that are out there, for better or worse. Perhaps we'll come up with a better way of technically moving that information. That style of information sharing between systems is going to continue. I think there's a role for continuing to exchange clinical documents. There certainly is a role for exchanging images, and then at the same time there is a larger and growing role that I think is going to be played by APIs as systems look to really be able to plug and play different pieces and fit together in sort of a mosaic of providing better patient care.
And kind of thinking about the system, kind of the ecosystem that all four of you have been describing, are we thinking about APIs as a clinician to clinician and healthcare organization to healthcare organization tool, patient or individual to healthcare tool, or some combination of that? And kind of depending on where we go, I think I'll also want to get into issues around what are the different challenges of developing APIs if you're thinking about who's going to be the primary intended user. So John, I'll kind of put you on the spot in terms of trying to pick apart all those questions.
Well, let's start with kind of the place where APIs are going to be best used. And I think that's in the provider to provider world. And I know that there are different kinds of programs and challenges out there to be able to have access through an API for patients as well. But I think that gets complex in that you have a system of APIs depending on who you're trying to access, that a patient will have to either go from place to place to place to access those records, or if there's an aggregator who sits in the middle and tries to provide that as a service, you have to think about how that aggregator is going to commercialize that, because likely not doing it from the kindness of their heart for the patient. So either from what I've seen, either something of value like data or the ability to use data in research or resell it starts to get to be the issue. I think that when you're thinking about the patient piece of it, APIs are less useful than a patient-centric kind of communication device where the patient can be easily set to receive information from their provider. And I think we've all understood that one of the concerns providers have around open access through an API is exactly what kind of information that the patient is going to have access to, if the context of that information is something that the patient can understand. And frankly, from a provider's point of view, to be able to have a patient interpret a clinical note, which in the context of being able to provide the best care for that patient is sometimes a brutal thing to read. I think as a provider, you'd much rather have some communication conduit to the patient where that medical record can be delivered to them in a way that is consumable by the patient. And I think that API is probably not where you need to be right now.
Well, this is Dave. I have maybe a little bit of a different view. I think that first of all, APIs are useful across the board, whether that's for provider-to-provider exchange, giving patients access into their records, and for health plans and potentially some other players as well, as you start to look at expanding the perspective of who we consider to be a player in the healthcare system. There can be lots of interesting actors out there as you think about folks providing community services in particular. I would certainly agree that there are some challenges on patient access, but I believe that those are solvable, and in fact that having the patients, as long as we solve some of those identity validation challenges and ensure that we have security around patient apps, excuse me, having the patients being able to take control of their own records has some advantages around taking some of the HIPAA considerations out of the picture that might otherwise be there around minimum necessary, for example, and exchanging with health plans, exchanging with folks who maybe would otherwise require a patient authorization, and there might be a paper process to release the records. So having the patient play those appropriate roles, and I think that's the important thing. Relatively few patients, there certainly are some out there, but relatively few, want to just aggregate their records to look at them. That we all want to play a useful role that is appropriate for us in the system, just as we do in other other industries. And I think that there is a room for that as we look to solve some of those challenges that are admittedly there around getting more widespread patient access.
Yeah, so the other thing I wanted to add to what Dave was saying, there are a lot of different groups that can participate with open APIs. And so we have the Carequality Alliance that are working directly on patient and caregiver solutions. We have the HL7 Argonaut project, which is working on largely exchange between providers. There's a HL7 Da Vinci project that's working on provider to payer types of interactions. And so I think we're going to see, over time, the whole gamut of different people connecting with each other or connecting to data through APIs.
Yeah, and the only thing I will add is I think probably the most critical phrase from the ONC interoperability rule is about access and exchanging and using health information through the without special effort through the use of APIs. So I think that kind of speaks volumes in terms of where the government sees the role of the patient and also exchanging that information, more broadly across the entire ecosystem.
And actually, Jeff, picking up on that comment in terms of the ease of access and ease of use, and I'll actually phrase this to you, kind of direct this question to you first, and then let everyone else weigh in. But are there concerns around the maintenance of the APIs? Because obviously we know once something is rolled, once any type of software or other tool is rolled out, it's not just a one and done. I feel like you're always seeing iterations, and do we have? Are there any concerns that an API could get put in place, people like it, but then the developer goes away, or any other kind of permutation there?
Yeah, I think that's still a work in progress. I think there are several different mechanisms that folks are taking advantage of. Chris mentioned the Carequality Alliance. I think is a good opportunity to figure out how to play in the API space and how companies that are interested in enabling greater access to data and enabling greater use of APIs can play in that space. And I would say as well that CMS, Centers for Medicare and Medicaid Services, is part of the My Healthy Data initiative. Has a pretty active sandbox still where they're looking at trying to figure out how to empower patients, how to put information in the hands of patients so they can be a bigger part of the care delivery process. So I think there's we're coming at this from multiple places, and I think that's helping push everything along here.
Yeah, I mean, we also have to remember that RESTful APIs, which is essentially what we're talking about with FHIR, is really not a new concept. We have the whole internet economy built on it, including Amazon and Google and others. And so there's probably a lot of best practices that we can learn from other industries and how to keep track of all those APIs and the maintenance and all those kinds of things.
Yeah, I understand that, but I also think that in some ways we might be overcomplicating what the real issue is, and that is the ability for patients to gather and be able to exchange their health information in a way that is useful for them and helps them manage their overall well-being. I think that there's technologies out there other than API that can be useful. And I think that if you think about this more as a push technology, meaning that the provider following the visit delivers the information to the patient rather than forcing the patient to go from place to place to place to gather their own health record, you simplify the problem and you make it part of the workflow as opposed to putting the onus on the patient, which, in all of the things that I've seen, it's up to the patient to go out and interact and get their health record. I think can be delivered to them in a way that is much more cost effective, a lot less complex, and much more cost effective and much more efficient for the provider.
I mean, I think there are use cases for a push model and the pull model in almost all different aspects of healthcare interoperability, and the same is very likely true for interactions with patients as well.
So I'd kind of like to now kind of transition to another area, and it's actually something that forgive me, but I'm not sure who mentioned it, but it was talking about kind of data or data standards. You know, I'm definitely not a technical person, but part of what I understand is for data to really be interoperable and or not really to be interoperable, but to facilitate interoperability and to help facilitate a common understanding, it's beneficial to have a common way for structuring the data. And the US CDI has been one of the frameworks that's been advanced. So I'd like to kind of get thoughts around what are the challenges around developing a common or core data set, and then given that US CDI is one of the ones advanced, I'll be honest, I'm not sure which one of the four of you might be best positioned to give a very brief primer in terms of what it is to make sure we're all on the same ground. But I think start with that and then kind of get into the challenges around driving adoption of the common data set.
Okay, yeah, I'll start since US CDI, or the US Core Data for Interoperability, is part of ONC and ONC's current proposed rulemaking, but it's a standardized set of data, and it's health classes and also constituent data elements for nationwide health information exchange. It's really setting a floor, not the ceiling, of the kinds of data that should be required to be exchanged. And so it's really, for those of you who know a little bit about the certification process at ONC, it really kind of replaces a common clinical data set that is in current certification. There's been kind of a colloquial use for that definition of common clinical data set, and the definition has gone beyond certification, and so this is a way to kind of reset the requirements, data requirements for certification going forward. And so we're also, part of what we're doing is also proposing a way in which we can continually add to that standardized data set.
And just to build on that, the US CDI provides, it's a little bit more than this, but in some ways it's a list of the required data elements. And then there's some additional work that's ongoing in the standards world to ensure that everyone has a standardized way of structuring the US CDI for purposes of exchanging them via the FHIR resources that we've been talking about in the API conversation. So there is a need to not only have APIs, but to have standard APIs, and that includes literally the APIs themselves should be standardized, and the work on FHIR has gone a long way towards starting to make that a reality. But then there's a second piece to it, which is ensuring that the information that you're exchanging via those APIs is actually interoperable, and that effort to codify how we exchange the US CDI is in fact taking the steps in that direction.
Yeah, and one thing that's always front and center for me when we're talking about US CDI is the comment that we made in our ONC proposed rule comment letter. What's included in 21st Century Cures related to electronic health information really talks about all the clinical data for a particular patient and making that exchangeable. How we kind of tried to frame our comments around the US CDI was, and EHI, was to really tie the definition of electronic health information to the US CDI and the current data classes. And then I think we tried to be a little bit innovative and think about kind of additional data classes that we would like to see rolled in the future. And that has to do with patient-generated health data, genetics information, all the things that I think we're talking about in the field, but look to try to phase those in the next 24 months after the rule is finalized, after we develop kind of a foundation for implementing the broader rule. So that when we talk about USCDI, that's the first thing that usually comes to mind for me.
Yeah, I also think that there's a real appetite out there to think about how you can use USCDI to also be a source to calculate clinical quality measures. And when you talk about expansion, I mean, you spoke about the patient piece of it. I think you also have to think about things like claims data and RCM to really be able to round out that picture if you want to use the data ultimately to evaluate the clinical quality measures as well.
So kind of, I think trying to piece together the comments from all of you is, Chris, one of the things that struck me in what you were saying is that the USCDI creates a floor, not a ceiling. And, one of the concerns that I have is when you have something that's implemented by a regulation and you create a floor, everyone runs to the floor, and then anything on top is either not taken care of or you scatter in different directions. It sounds like, I think from what Dave and then Jeff and John were saying is, that while that, we only have a floor here, does seem to be some collective effort to create the add-ons and the additions in a collaborative manner that's going to serve, hopefully serve everybody. But is there a concern that, if we have a breakdown in those relations, is there going to be enough that can be driven from a requirement perspective, as opposed to some, relying upon, the continued goodwill and good faith cooperation among, private parties?
Yeah, so, well, a couple of thoughts. So first of all, as I mentioned, there's a process in which over time we'll continually add data elements, and so that gets to part of what you're talking about. But we also, through our experience with CCDS, or the Common Clinical Data Set, that looked at that was viewed as a ceiling, and so that was part of the issue. We're trying to stay away from setting a ceiling, setting a floor, and let people build on it. But we think, but the overall strategy, though, if you take a step back and look at our overall strategy, through secured standard-based APIs, we are trying to establish an ecosystem which innovators can go and innovate on top of that, and innovate for services that different people might need, providers, patients, payers, and others. And so I think as we create that ecosystem, and as we get some competition, and as application developers are trying to meet people's needs, I think we can we'll see that it won't be stuck as a ceiling.
I think Chris had a really interesting point there on market dynamics and competition, whereas you think about APIs being standardized and the information that you exchange being at least partially standardized, where do people start to compete? And those additional offerings, I mean, there's a whole host of areas where people can still compete. I don't actually have any concerns on that, but this is one of those areas, the ability to expand on the USCDI and to usefully provide access into other types of data.
So in thinking about that development, and the ability to innovate, I think all four of you at this point have mentioned FHIR, and FHIR being, hopefully I'm not mischaracterizing this, but kind of the framework or the baseline from which the APIs can be developed. I think I read a story recently questioning whether FHIR was the best framework to be utilizing. So I would like to actually turn that question out to all of you and say, is FHIR the right framework to be using, or are we going to be drifting away from it, in the I guess near or long-term future, and how could it be improved? So Dave, I'll actually turn that over to you first, because I think I've heard you mention FHIR the most.
Fair enough. So yeah, and I chuckled as you asked the question, because I was at an OMC Interop forum, a year or so ago, where people were standing at the microphones and were saying, we need to get to FHIR, we need to get to FHIR, FHIR needs to be there. And I turned to the person next to me and I said, you'll know that we will have made progress and that FHIR is really about ready to take off when people are standing up those microphones saying fire hasn't solved the problems, it isn't moving fast enough. Ultimately, we need you need to have a stake in the ground. You need to say this is the standard and we're going to follow it. And you can always have folks who are going to argue about whether there's something better or not. And obviously you could take the argument too far and pursue a wrong standard, but I don't think there's any evidence that fire is a wrong standard. It has a great deal of support in the industry, and I think there's a lot of momentum towards focusing energy on making the improvements where improvements are needed, and ultimately that's what you have to do. You have to put the marker down and say this is the standard we're going to follow until something truly better emerges over time, which eventually will happen. But that's a long time out, and there's a lot that we can do to improve fire in the meantime.
Yeah, I just want to add to that too. One of the things I think indicated it's a good standard, at least it's well supported. So you can't go to a health IT conference without everyone talking about fire and about wanting to get to fire. Also, I'll point out there's a blog post that was written by Steve Posnack and Talisha Searcy, from ONC in October 2018, so about a little over a year ago. And there was some research done. They found out that, looking at CMS and ONC data, about 87% of the hospitals and then 69% of the eligible clinicians were using EHRs that had open APIs, and fire was, in the majority of those. And so I think we're already seeing a lot of adoption of open APIs based on fire.
Yeah, I think as you think about real interoperability, you've got two conditions, and the first is, I guess, is the technical interoperability, or how do I get stuff from point A to point B. The second component there, I think it is important to keep in mind, is semantic interoperability, the ability to transmit data from one place to another with meaning. I think fire may be challenged in the area of semantic interoperability because of the use of different coding systems. It'll require data normalization regardless of the transport technology employed. So while I think fire holds great promise, without a mandate, and while I'd say that there is a strong tendency in healthcare to want to use fire, it's certainly not what I'd call a full consensus. There's still some challenges ahead to say that you can adopt it as a true standard.
Yeah, and I think as John mentioned, I don't think that there is quite a mandate yet, but I would just emphasize what's included in the ONC rules, interoperability rules, and I think ONC is pretty deliberate in kind of asking not the question whether to use fire, but actually what version of fire to use. So I think that that's an important piece to just mention in terms of when will fire-based exchange be mandated. And I think we'll see a lot of that. I'm assuming we'll see a lot of that in kind of the ONC and CMS rules when they're finalized.
Yeah, and kind of given. Oh, sorry. Go ahead.
Yeah, I was just going to say, to go very briefly on what John had said, because I think he made an important point there that's worth sort of re-emphasizing, that fire is more or less a transport standard, which means that it's telling you how to get the information from point A to point B. It's not necessarily, at least at the core of the standard, telling you exactly how to define the payload in terms of the data sets to use when you're specifying a medication, for example. And John's absolutely right that if we think fire is going to magically solve that problem that we haven't solved in clinical documents, for example, then we're setting ourselves up for disappointment, because we do still need to ensure that those terminologies that we're using as we exchange the information are also standardized.
So, and actually picking up on that point then, if fire is more of the transport as opposed to the semantics, is there a standard out there that would hit on the semantic side of the equation?
Well, fire is partially semantics as well, but where it's not necessarily specifying, unless you actually go into the and don't want to get too overly technical, but until you actually go into the resource definitions and say, thou shalt use terminology standard X for this. If you just say, send a medication, that is not sufficient. So some of it is, it's not so much that FHIR doesn't get us or can't get us to what we need to do semantically. We just need to not fall into the trap of leaving it unspecified. We need to make sure that we're specifying down to the terminologies to use.
Yeah, so it sounds like that kind of goes back to the prior topic of having the common data sets and having a common understanding of how we want to structure things, so that way, if you go from system A to system B, it can translate easily, as opposed to, I feel like maybe this is hopefully an outlier example at this point in time, but some people enter the date in a different manner. So you move it from one system to another and the date doesn't fill in correctly because maybe you go month, day, year, and another goes day, month, year, or some other variation on it. And it seems like no matter what we do with the technology, if we don't have the agreement on this is how we want to structure it, then the technology is going to continue to face challenges.
Yeah, well, that's exactly true, and I agree with John and others that talked about this. I mean, it is something that we continue to chip away at. Some of it we can resolve through rules and through ONC processes. We try to address some of this in our interoperability standards advisory. We publish on an annual basis a list of standards and implementation specifications that help meet interoperability needs. And within there, we try to help guide. It's not perfect. We continue to expand and to refine, but it's a process though where we engage with stakeholders to try to reach better levels of interoperability.
So kind of, I know we've spent a bunch of time in terms of kind of the technical side of interoperability. What I'd like to go to now is, and this is a topic that has already been alluded to, is information blocking. And I know Jeff was referencing the proposed rules from both ONC and CMS on it. So my first question is going to be, I think information blocking gets a lot of press, and depending on who you're asking, it's either validated because you need to highlight this issue, or the other perspective is it's overblown and it's not really as much of an issue as you might worry about, or as might be made out to be. I'm going to go from the assumption that there are information blocking concerns, because I would hope that you wouldn't have a major piece of legislation and then a very significant set of proposed regulations if there wasn't an actual concern. So working from that assumption, what are the biggest challenges around information blocking, and with the identification of that challenge, are the proposed rules going in a direction that is going to address a particular challenge? So I guess I'll let Chris go first on this one, since I suspect you have a particular vantage point, having been involved in the creation of the regulations, and again, understanding that they haven't been fully promulgated yet. So I bet you have some restrictions.
Yeah, actually, this is an area where I probably can't say a whole lot, but I will have to say that, to one of your points, defining information blocking, and then trying to separate when there's information blocking and then when there's legitimate reasons why people don't share information. And that was actually the responsibility given to ONC through the 21st Century Cures. We've been spending a lot of time thinking about that and working on that and getting public feedback on those issues. And so that's all I can say at the moment.
Yeah. I'm sorry, go ahead.
No, John, please go.
I think what you've got, in the reality is it's a fragmented environment. Organizations are at various stages of adopting value-based reimbursement. Nearly every connection between disparate systems has been built as a one-off. Laying out a clear and enforceable rule for what constitutes a purposeful withholding of patient data, to me, would seem nearly impossible.
So, and Jeff, I suspect you have some interesting insights, because I know having been involved in the process behind trying to prepare Hims's comments, it's there was a lot of spirited debate that occurred.
Yeah, and I think the biggest thing that we heard in developing our public comment letter on the ONC rule was that interoperability and information blocking was not necessarily a technical issue. That information is primed to be moved. There are I think we touched on a couple of the big issues already in terms of how information gets from point A to point B, but overall, it's not really a technical issue to move that information. I think the bigger issue is really around the entire healthcare marketplace and where reimbursement is based and where business models are based around. I think that there are some disincentives to sharing information broadly across the entire ecosystem. I think that the information blocking rule in 21st Century Cures was kind of put in place to try to address some of those concerns. But I think where we tried to really focus was trying to make sure that that the 7 exceptions that were defined as a part of the rule were really headed in the right direction. I think one of the things that ONC, it's important to note, ONC was charged with under 21st Century Cures was defining the reasonable and necessary activities that do not constitute information blocking. So they had to define the exception. So they were coming at it from kind of probably a different angle than one might necessarily come to discuss this kind of situation. But some of the 7 exceptions, I think, hit on the big areas that we need to make sure that are being addressed as we think about sharing information more broadly. One thing that we did put in our comment letter was the idea of actually kind of providing some guardrails and asking ONC to provide some kind of more information around what a healthcare ecosystem that's sharing information more broadly would look like. So it's not just talking about what the exceptions are when it's okay to not share information, but also kind of trying to put a little more positive spin on how what things would look like and what would be the kind of parameters around broadly sharing information.
Yeah, I think I would largely agree with what's been said. I think John was correct in where he was going with it. It's really hard to identify where on the spectrum things fall between somebody who's just purely information blocking and somebody who is facing real challenges. And unfortunately, there's an awful lot of middle ground in there where people are facing challenges in getting information to move, and they look at it and say, you know what, I just really don't have that much incentive to solve these challenges, and they're kind of hard, so I'm not going to do it. And exactly where you draw that line is a little challenging. So, Chris, I don't envy ONC their task that they have there under the legislation. The model with having the exceptions defined, the model with having those exceptions defined, I think, is one that makes a lot of sense. It's just a matter of seeing how that all plays out in reality.
Yeah, and I agree. Kind of defining it through the exception, so that way you're kind of hopefully creating narrow bands where you're not engaging in that are kind of outside of the requirements. But one of the concerns that I might have is and I'll pick off on 2 of them, which are focusing on compliance with other privacy or security obligations. And I think we've seen a lot of, I'll call it, difficulty in accurately complying with existing regulations or existing requirements. So are we concerned that we're just going to have a continuation of those same challenges through either deliberate or unintentional misapplication of the carve-outs?
And I think you put on top of that a patchwork of that state laws that can be difficult to manage when you think about sort of the sharing across the larger expanse of the U.S., right? It starts to become a difficult issue. And the other piece of it, as of the rules compliance, which from last I saw was supposed to be 2020, it seems that there'd be a major concern as to whether or not HCOs and providers can get there without really taking a significant economic hit by having to do a whole bunch of development in a pretty short amount of time across this set of requirements.
Yeah, no, and John, I like the reference to state law because I think that is a part of the equation that's not necessarily readily apparent at first, but it does definitely present real challenges, even if the federal level law is kind of where the focus is and used as the reason for a particular practice occurring. But kind of also connected to all this, and I think connected to a lot of the broader discussion is, and I think all of you have talked about it to some degree, is the potential economic disincentive for pursuing the ability to have all the data kind of flow easily and to have these easy connections. And that seems to go into one bucket of want to traditionally keep your patients, because if you're fee for service, you need to kind of keep them in your silo as opposed to collaborate. But another angle is arguably intellectual property concerns of not wanting to open up your system to someone else to potentially learn how it operates and then kind of take pieces of it and develop their own solutions. So I'm wondering if you guys have some perspectives on where IP comes into the discussion around interoperability broadly, and then kind of diving into some of the challenges.
Just referenced earlier in talking briefly about the comments that James had made on the rule, the definition of EHI, and we had some similar comments along those lines, that the definition of what the information is that's actually covered by information blocking is extremely broad. And I do worry a little bit on a number of fronts, from practicality, but also including that the intellectual property side of things, that if you have this extremely broad.
Dave,
Yeah,
I'm
I think
I'm sorry, you were breaking up a little bit. Dave, your phone was breaking up a little bit. We did. I don't know what you can do about that, but maybe we could circle back around. But was I the only one hearing that, or was everybody hearing that?
I think we're all hearing it.
Oh, okay. Yeah,
breaking up.
Yeah,
he was breaking up.
Well, while Dave works on his technical problems, Chris, Jeff, or John, one of you want to pick it up?
It seems to me that kind of the world of open source is where most of the really interesting stuff is going on. And since that software is fully reproducible and source code is provided, it's really about being able to profit from selling their expertise through consulting, customization, support services, rather than selling copies of their software. And I think as you see that model take hold more and more in the world of technology, the IP becomes less and less the area of concern. Open source, you can basically open source just about anything that you need to do from a technical point of view to be able to have your HCO function well and be able to have a solid patient record system. So I think the IP piece is starting to get actually less and less of a problem as time goes on.
Yeah, and I'll just add really quick that as we standardize on the data sets, and everyone's exchanging the same type of data, the same way, that eliminates a lot of the IP issues, at least in my personal belief.
And this is Dave, switching modes here. Hopefully you can hear me now.
Yes, much better.
Excellent. I was agreeing actually with Jeff's earlier comments that one of the things that's really important as we think about information blocking on a variety of fronts is the definition of electronic health information, or EHI, the information that's actually in scope for the law. And ensuring that isn't too overly broad for a variety of reasons, but one of which would be that intellectual property consideration, where if you have a standardized set of it's still broad, but not the kitchen sink of information that is expected to be shared, that puts people on sort of an even playing field with respect to sharing information, and is less likely to inadvertently divulge something that they're trying to protect.
Those are actually interesting perspectives, because it's based on some of the experience I have working with some of my clients, I'm not sure that there is that focus on the open source and moving away from wanting ownership of the software, because I've actually had a couple different clients have systems say, oh, your solution looks great, but we want you to customize it, and then we want to own the whole thing. And it's kind of sticking back in a more traditionally focused model, where I think the view is ownership of the tool is the most important, as opposed to, John, the point you're making, which is it's the service and kind of the know-how of being able to create the connections without necessarily the underlying IP itself being the most important part.
As you look at the things that systems do and how they do them, and while certainly there is fierce competition for software dollar out there, the fact of the matter is that they all pretty much do the same things the same way. And as you start to think about this, the role of the software vendor is going to change pretty substantially over time. And I don't think that time is too far away, where, again, the value proposition becomes being able to take something that's out there and fit it to an organization, rather than to buy a base package that, whether I'm this brand name, that brand name, or the other brand name, guess what? Does the same stuff.
Yeah, and I think John raises a good point in terms of what ONC talked a lot about in their proposed rule was about leveling the playing field and trying to encourage innovation and new market access, and in terms of new market entrants, I should say, in terms of more companies wanting to play in this data space. And they set up they proposed a fee structure that we could spend the rest of the time of this conference call kind of discussing, but I think the fee structure is important in just a general sense, related to leveling the playing field, trying to eliminate some of those silos that exist across the community, and trying to encourage more information to flow more broadly.
Yeah, and actually kind of thinking about being ready to have the information flow, and this also kind of builds off of the point that Dave and Jeff, both of you were making in terms of the definition of electronic health information, and then also, John, as you were saying, when is the actual compliance date going to be when these final rules are actually available? What is being done right now to prepare to be able to transmit and allow access to EHI, and what should be occurring right now, so that way people and organizations aren't completely caught flat-footed. So, John, I'll let you kind of lead this one off, as you're at least the one in my most recent memory who is specifically touching on the topic.
Yeah, and I think that there's administrative burdens that have to be understood. I think everybody acknowledges that there's that burden. I don't think it's really clear where the consideration and judgment of regulations are aligning with that burden. And I think that as far as the healthcare community is concerned, we need a little bit of understanding at the user level about the runway necessary in order to get there. We just have to be a little bit careful that we're not pulling the trigger too quickly and trying to move things into an environment where the dollars and cents and the administrative burden are just crushing to an environment or an industry that is by and large struggling to make sure that they are able to deliver on their mission day after day.
Yeah, and I know Chris can't really talk about this, so I'll jump in and just say that I think that ONC was handed a tough task in terms of implementing the information blocking piece of 21st Century Cures in terms of the time frame, and I think the expectations from members of Congress. It's obviously been a huge undertaking, and they've engaged in a real public process and did a ton of stakeholder meetings to try to gather information about how they should structure their rules. And now I think that we are likely to see, kind of as John described, a glide path in terms of when the rules will be finalized. And the actual implementation will start. So I think the key thing, Matt, you asked the question about what folks are doing now, and I think folks are, beginning to think about the steps that they will need to take when the rules are finalized. But I know that people proceed generally cautiously in terms of what they actually develop in terms of all the technical requirements that will be included in the final rule until they actually see it included in the final rule.
Yeah, I would agree with that. I think that folks are probably waiting on doing any new development of technology, where I think that there is a fair amount of work going on, and if there isn't, there should be. Is likely on the process documentation side. There are a lot of things that in order to fall into the exceptions, they need to be in documented and published processes that probably just are not there today as far as having those processes laid out as well as they should be. So I expect that that's where a lot of work is underway or certainly will be soon if it isn't already. And I expect that to continue for some time.
And Chris, are you able to share any thoughts from your perspective?
No, not really. Sorry.
Yeah, and I guess probably the one thing I would add in is, talking about the administrative cost is, I hate to say it, but the regulations are typically have a very big undershot when it comes to the actual time and cost. So I think, if you can begin to plan ahead at this point, it can help ease the path, even if you're not sure what that specific pathway is going to be. At least having a sense of, from the proposed rule, what could be there, because I think more often than not, you don't see major shift in policy from the proposed to a final rule. Although, if might also want to consider what comments have been submitted, just to see if there was arguably a broad consensus among commenters around an area of concern within a rule. And so kind of thinking about those challenges, in understanding that maybe it's hard to take immediate steps right now, what do all of you think will be the biggest challenges for organizations in terms of being able to prepare for the transmit and access? And to some degree, I kind of think about it of, there should have been a lot of access already, since we have a fairly well established right of access under HIPAA, regardless of how well that's respected in terms of how requests go in. But thinking, from each of your opinions, just thinking about what the proposed rule is and where you might hope the final rule goes, what would your advice be in terms of steps to take? And I'll start with Dave on this one.
Well, I think first of all, everyone needs to be thinking about their overall compliance framework and how information blocking fits in, and making sure that they really are thinking about it along those lines, making sure that they have compliance plans in place, and that their folks who are on the compliance side are thinking about this carefully. Then, it's a little hard to get into any specifics until we see the final rule, but based on the policy directions, obviously there is going to be an expectation of more information sharing than is out there today, especially with respect to sharing information with patients. I think also with respect to provider organizations sharing information with health plans in ways that maybe they aren't today. Not so much that the health plans aren't getting the information, but that they may be getting it in some different ways that are more in line with how provider-to-provider exchange is occurring. So just being prepared for that from both a policy standpoint, and then starting to think about prioritizing the technical side, because you simply aren't going to be able to do it all at once. So prioritizing on the technical side where you think your greatest risk or opportunity lies, I guess, depending on your mindset about it, I think is going to be necessary too.
Yeah, so I'll just add to that. I think, and this is more, I'm not necessarily speaking on behalf of ONC. Just when I'm out and about, though, I still hear a lot of complaints from patients and caregivers about getting access to the information. I know that, through 21st Century Cures, there's an emphasis like Dave was talking about, and I know there's challenges like John was talking about, but that's something that that's going to be a real emphasis on making sure that patients and their caregivers do have access to their information as specified in the HIPAA regulations and subsequent rulemaking.
Yeah, I think in general, you have to be on a path and be able to demonstrate that you're on a path. I don't think that any of the regulatory agencies want to be punitive to somebody who is struggling to catch up and just not there yet. And at the same time, I can't help but think from a workflow and ease of compliance point of view, that organizations that have sort of a push mechanism so that patients have the data that they need quickly after a visit in a place that's easily accessible by that patient or owned by that patient, start to be in a position where they don't have to think about, how do I manage all these requests coming in? Sure, you'll get some of them from patients or other entities that weren't able to correctly file or hold on to what you've pushed them. But I think by pushing, you wind up putting something in a workflow that is easily executed time after time, and that's where HCOs are most efficient, when it's a standard workflow and being able to do the same steps over and over and get ahead of the game.
Yeah, and the only thing that I'll add is I think that as we kind of talked about, this is largely not a technical issue, but I do think that there are providers and stakeholders across the community that have begun to ensure that they have the right systems in place. So when they do see a final rule and they do see a compliance date, they are ready to meet the requirements, given the onerous civil monetary penalties that kind of apply for those folks that are deemed information blockers. So I think folks are primed and ready. It's just a matter of seeing the rules at this point.
Yeah, so if we're thinking about everyone being primed and ready to go, this shifts into a broader, maybe not necessarily interoperability specific concern, but the debate over privacy, and how do we protect privacy, and frankly, how do we even define privacy at this point in time? I know the information blocking rule talks about privacy, and if you have to meet the HIPAA privacy requirements, and if that is a reason for not sharing data, then that's going to be allowed because you're not overruling another set of regulations. But we're also starting to the point that we were talking about earlier of state law coming in. You've got state law layering in, so we don't, there isn't necessarily a comprehensive privacy regime, although that's, I think we're probably all aware being somewhat debated. At least there's legislation introduced. So just want to get perspectives in terms of where do you see privacy coming in, and where, how do these rules, offer an opportunity to enhance privacy, and at the same time, where could it be a challenge to maintaining privacy? So Jeff, would you like to lead us off?
Sure. I think that it's a critical component to any sort of broad information exchange effort, and I think ONC spent a lot of time in their proposed rule, kind of highlighting the importance of patient privacy and protecting of personally identifiable information. I think it really goes back to the point of maybe some reticence on the part of some members of the public to want to broadly share their information because they are worried about different privacy issues. So I think ONC and across HHS is really tried to look at and try to use all the different vehicles that they have available to them to try to, as we've spoken about, kind of highlight the HIPAA right of access and highlight all the different requirements around exchange. There have been a lot of efforts across the entire department, from the HIPAA RFI, and I do think that we will probably see a HIPAA-related proposed rule in the near term, and also around the 42 CFR Part 2 rules about exchanging information. So I think the government is trying to use all the policy levers that they can to try to facilitate more exchange and try to provide folks with really the wherewithal and the knowledge of how their information should move as we begin to think about kind of the final rules.
Yeah, I mean, just to play more on what Jeff was saying, and I appreciate, Jeff, that you recognize all the work that ONC has done working with our federal partners and the Office of Civil Rights and others to try to get this right. And so within the rule, I think you'll see some things on security, which is tightly coupled, of course, to protect privacy. And we spent a lot of time thinking about that. We spent a lot of time thinking about the area of information blocking and what some exceptions would be in regards to protecting people's privacy. And so there's some things that we proposed in the criteria. For example, it's attestation, but ensure that the health IT modules encrypt and encrypt authenticated credentials and support multi-factor authentication, and also using OAuth as part of the API. That's one of the things that I think was proposed. So, just trying to get the security addressed.
Yeah, it's got to be a very tough balance. I mean, you don't want new policy changes to potentially impede the transformation to value-based healthcare while still being able to ensure that the privacy needs of the individual are met. So it's a very tough issue, and I think that anytime with respect to HIPAA that you change things, that's also a ripple effect through the community, because a change either making information more shareable or closing gaps on privacy wind up having to end up with a lot of programming, a lot of development, and a lot of rule changing that has to get down to the caregiver level so everybody understands. So in either case, you're really creating the potential for confusion. and it's a tough tightrope. So I really I can really understand the position that ONC is in.
Yeah, I would agree with that. I mean, I won't repeat too much on the tension that everyone has covered. There clearly is a tension there. The one thing that I think is interesting to observe as we think about some of the, I don't know if there's social factors that you would call it, but we've had 2 decades to sort of institutionalize HIPAA compliance across healthcare, and there's a lot of weight behind that. Until there is some countervailing weight of actual enforcement that's taken on information blocking, I think we'll continue to see that we err on the side of privacy as opposed to access. And you know, that will gradually change, but I think we need to be realistic about that. Just sort of built-in mindsets of HIPAA, especially in the provider organization world, it's going to take some time and maybe some painful lessons to sort of shift some of that institutional balance.
Yeah, I just want to say one thing, but Dave's absolutely right. And more recently, but I'll say prior to rulemaking, you know, one of the really focus of ONCs, and I think you saw it in some of the proposed rulemaking as well. You know, there is an emphasis on getting patients and caregivers their data. And we have done a lot of work with the Office of Civil Rights and making people aware of what their rights are, trying to encourage people to exercise those rights. And so, you know, kind of the softer side of things, trying to just, you know, make people aware of what they can ask for and the expectations that they can have for their physicians and other providers.
Yeah, no, I definitely agree. There's been a lot of emphasis and guidance, and you know, in the past couple months, you know, now a couple fines issued by OCR around the right of access. So, Chris, I fully agree with you that it's definitely been a point of focus. So, actually, guys, as we're really starting to get close to the end of our time, what I'd like to do is kind of allow each of you to make a little bit of a concluding remark. And you know, the way I'd frame it is, you know, the first part would be is if you have any final kind of immediate wisdom that you'd like to share around interoperability. And then the second, given that we are, you know, at year end and it's prediction season, you know, what do each of you predict we'll be talking about on this panel next year, given that this is the 4th annual, and I highly suspect that the number will well exceed 5 and beyond. So I'm just going to go down the screen the way that I'm looking at it. So Dave, you're up first.
All right. So, you know, I think that, first of all, interoperability is a journey, and I think sometimes we lose sight of the fact that we really have made a lot of progress. And we keep moving the goalposts, which is a good thing. We should keep moving the goalposts, but I think we need to be cognizant of the fact that that's actually what we're doing, that we have made a lot of progress and that we're correctly looking to improve on it. But there is a lot that's already happening. And it's a matter of expanding on it. And I do actually think that the information blocking rule is ultimately going to have some benefit in expanding some of the progress that we've made, especially in the provider-to-provider interoperability world, and opening that up more to both patients, but also into other players as well. I think the rule is going to play an important role there. As far as predictions, I think you'll continue to see more work being done on APIs and more talk about APIs, and maybe right around this time next year we will hit that point where we say, oh my goodness, APIs aren't what we thought they would be, and I can't predict that is exactly because they're now actually starting to have meaningful impact in the real world. And then selfishly, I hope that by this time next year, there's a lot more to talk about on the trusted exchange framework and common agreements that is coming out of ONC.
Chris.
Yeah, so my closing remarks might be just a tad bit different coming at it as a regulator, but I think you're all aware that 21st century cures is the current policy imperative that we're following. You know, we talked about the ecosystem of secure, standardized APIs. We talked a lot about, you know, info blocking, trying to address that, making sure that patients have better access to their data. But really what we're trying to do with all of these things is really trying to create the precondition for truly transforming healthcare. And our policies and programs are really trying to get patients to play a more active role in their healthcare decisions and managing their health. We're trying to do things like improving scientific discovery and then enabling the things that are learned to be actually, inserted into practice. We are just collectively trying to, as was mentioned by Jeff earlier, trying to lead people, application developers and others, market entrants to create more competition into the healthcare field and create better, affordable, patient care. And so really, that's our focus. That's why we're doing all of these things. So my prediction, what we talk about next year, one of the things I hope we're talking about next year is actually the trust exchange framework, the common agreement, and things are probably near and dear to Dave's heart. I think, we'll see a lot of, by then we'll see some movement in that area as well. And so part of the dialogue will not only be APIs, certainly be APIs, but also be the network to network kinds of exchange, and what we're doing with that and where we're going with that.
Yep, Jeff.
So I think one of the key takeaways, and I think we've touched on a lot of the issues today, is the interconnectedness of interoperability to so many other policy issues, and value-based care delivery, and clinician burden. You can't deliver value-based care without broadly sharing information across the entire ecosystem. So I think it's important to kind of mention that I think we're close to a pivot point in terms of when we do see the final rules and when information is being shared even more broadly, that we could be helpful to broadly sharing information and facilitating more value-based care delivery, and then also the idea around trying to minimize clinician burden and trying to minimize the time that clinicians spend trying to share information with other health systems, other physician offices, etc. So my one prediction is since everyone has already said TEPCA, I won't say TEPCA, but I do think that come next year, hopefully we'll be talking about how great implementation of the ONC and CMS final rules is going, and how information is moving even more seamlessly across across all stakeholders.
Now, John, you get to have the parting thoughts.
So, when I watch the Olympics, everybody seems to focus on the sprinters and the people that are at the front of the pack. And I think the reality of our healthcare system is that we've got a very large middle of the pack that is still dealing with paper processes, still dealing with forms, still dealing with signatures. The way that healthcare is delivered, by and large, while we've made advances in the delivery of healthcare through electronic means, is still highly manual. And I think that there has to be a ton of work left to do to adopt electronic workflows into the real world of how care is delivered, not only in settings like hospitals and university clinics, but really across the board to post-acute care and home health care, where the idea of being able to share information like this is light years away from the reality of what these caregivers deal with every day. And I think as you start thinking about what kind of technology to apply and how to think about the economics of those kinds of caregivers, you also have to say, as you go through the rulemaking process, what ways can I encourage the small steps that are going to start to get us to a place where you have a lot more of a lot more participation at the provider level. I think the last stat that I saw, and certainly from the industry that I'm in, electronic transactions of healthcare information through any means other than fax are absolutely dwarfed by fax? And how do you start to address that in a way where an electronic workflow takes the place of something that's trusted, used every day, and part of really the fiber of how work gets done at the clinical level? And I think that those things need to be addressed. So what my prediction is actually more of a bit of a fear that we're going to continue focusing on the edge of the spear, and in doing that, not necessarily bring the vast middle of what most healthcare providers are struggling with every day, to be able to get the information in electronic format where we can start to think about taking the next steps and how we do those things.
Yeah, no, a lot of great considerations, and thank you all for joining the panel today. Very much enjoyed the conversation, and again, thank you, and lot for everyone to consider as they as takeaways.
Appreciate it.
I agree. And Matt, thank you for committing yourself to the 5th annual panel discussion. And I think I'm going to actually, Don, Dave, Jeff, Chris, you'll be seeing an email from me probably in about 9 months, getting you back on the 5th. I hope you all have a very happy holiday season, and look forward to hopefully meeting you all in person at HIMSS. Thank you, attendees, for taking time out today in a busy schedule, and we will see you back again next year.